Audio, please share audio.
सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत्
Hello, viewers. As we all know, health is true wealth. True Wealth Integrative Health Centers were established with the mission of Sarve Bhavantu Sukhina, Sarve Santu Niramaya, true wealth of holistic health and happiness for all, to reverse, control, and prevent diseases and augment health by integrating all appropriate scientific, evidence based, personalized nutrition and fitness therapies, functional medicine, and advanced surgical treatments with a holistic wellness approach. Which is why True Wealth Integrative Healthcare is here today with a critical topic of brain tumors. Early detection of brain tumors are important as they can greatly improve the treatment outcomes. So to let us know more about brain tumors, let's go on to the experts right away. The faculty here is absolutely a experienced, knowledgeable one, and they're extremely practical and simple in their approach in explaining to us more about brain tumors. And for that, we have Dr. Amit Aiwale and Dr. Deepak Aiwale from the Institute of Neurosciences at the renowned Solaris Hospital in Thane. I, Rajashree, Gadgil, the founder of True Wealth Integrative Healthcare, with 24 years of rich global experience, take this proud privilege to introduce both of them. Dr. Deepak Aiwale is a senior consultant neurologist for past 2 decades and is attached to, of course, the Solaris Hospital, Jupiter Hospital, Bethany, Hiranandani, and other hospitals in Thane. He started a dedicated neurocare center at Solaris Hospital, which is one of its kind, multiple super specialty surgical and medical center equipped with recent innovations. He has treated more than 20,000 patients with various neurological issues, especially Parkinson's disease, stroke, dementia, neuropathy, epilepsy, tumors, and much more. He has vast experience of treating autoimmune neurological disorders like multiple sclerosis, demyelinating disorders, myasthenia gravis, GBS, inflammatory myopathies, and more. He has many national and international publications to his name and lifetime member of World Stroke Organization, Indian Academy of Neurology, Movement Disorders Society of India, and Indian Epilepsy Society. We also have Dr. Amit Aiwale with us. He's the director of Solaris Hospital and associated as a senior visiting neurosurgeon at the Bethany Kaushalya and Mahavir Jain hospitals in Thane. With advanced training in neurosurgery for Care Hospital in Hyderabad, He is fellow of the World Federation of Neurological Surgeons. Having performed over 1,500 brain surgeries and more than 5,000 spine surgeries, he specialized in stroke, brain tumors, aneurysms, AVMs, head injuries, and trauma and various spine disorders. He is also skilled in endoscopic brain surgeries such as pituitary tumors, intraventricular tumors, and third ventriculostomy procedures. At Solaris, he has introduced navigation guided brain and spine surgeries. He received the first prize in Next Gen Young Surgeon Awards in 2018 in the International Neurosurgery Update with the abstract presentation. Welcome to both of you, Dr. Deepak Aiwale and Dr. Amit Aiwale. It's such a proud privilege to share the stage with you and to know about such an important topic, such a critical topic, really. Would you like to say something before we actually start shooting questions at you? Dr. Deepak, if you can please unmute yourself.
Yeah, thank you, Rajashree, for such a wonderful introduction. It's always a pleasure to join you. And I think you have chosen a very good topic. It's an alarming issue. People are usually terrified by just a hint of such illnesses. But with proper awareness, I think they should be able to face such calamities. So I think we need to know more about brain tumor. General public needs to know more and make wise decisions with proper guidance. I think today's session will focus on that so that we could give some insights into how a general public should approach our case of brain tumor.
Yeah,
Great,
yes, because in day-to-day life we see people. There is no person in the world who has ever had headache. Every person on the earth has at least once felt headache. So headache is such a small symptom, but when that headache is associated with the brain tumor, the things become so vast and drastic for the patient. So how to identify your symptoms is the basic thing that any person or any general practitioner or any physician who treats the headaches need to understand. And I think today's session definitely will add light to this and make our minds clear.
Audience, you probably already gathered why I was saying that they are knowledgeable, experienced, and at the same time very simple in explaining things to us, because this is even while we went to school, brain or nervous system was always such a complicated topic which we would keep aside. But having to know simple things like just a headache could actually be an alarming signal to a grave disease. So I think, even despite how much, there's so much minimal awareness about brain tumors as such. So, in first place, we don't even know what brain tumors are really. The only brain tumor we probably know is the Amitabh Bachchan movie where he gets a brain tumor and then realize that it's detected that he didn't have it. But what exactly is a brain tumor? And since the cases are the cases also on a rise.
So I think with growing age expectation, with facilities, medical advances, living standards improving in last 2 decades, your life expectancy has gone up, and most of the tumors which are there, which are the malignant ones, usually are more in the beyond 50s or 60s. So as your aging population is increasing, the incidence of detecting brain tumors is increasing. Now, how to look at it? 2 extreme age groups. One is the infants and kids, and other is the elderly population. So usually infants and kids usually have some germ cell tumor, or tumors are benign, but because they are the age group is such vulnerable, it is very difficult to identify unless you are aware of the symptoms. And in old age, again, you have to look at with suspicion the headaches. So headache is the most common symptom of if you have to suspect, any suspicion has to arise, this has to be headache. So usually the headache is more in the early morning after having lied down in the bed for overnight. There is raised intracranial pressure. And so if anybody notices sudden change in character of headache or a new type of headache, which is more in the morning, early in the morning, that could be a suggestion to consult a doctor. If it is increasing on coughing and sneezing or straining at stools, then that is a suggestion to suspect. Obviously, not all what you can say age groups have similar incidences. So as I said, elderlies have to be we have to be more suspicious. Again, when you add one more symptom, that is vomiting, that is a symptom of projectile vomiting, a symptom of raised ICP. If such kind of thing is happening, that headache is worsening or vomiting is getting added, then again you have to suspect. And then depending upon the location in the brain. So location in the brain, supposedly it is in the frontal lobe. Frontal lobe is the anterior part of the brain. So frontal lobe is associated with execution of work, judgment, decision making. So anybody who has been wise until recently but has been complaining of headache and has some mild impairment of his behavior or judgment, I think we should be suspecting and consulting a doctor, where you might see that there is a lesion in the frontal lobe. Also, frontal lobe is associated with urine control or balance. So frontal lobe tumors can present with cognitive impairment. Previously, intellectual and a person with good intellect is not doing well in his daily activities. There could be an imbalance. There could be incontinence of urine, and then you have to suspect that this, along with headache, has to be a frontal lobe. Similarly, a tumor in posterior, slightly behind the frontal lobe, over the parietal lobe. A parietal lobe has your sensory integration. So somatosensory integration, it could affect your touch or paresthesias, or that is called as tingling or burning in the limbs, or any twitching over face, that can give you a hint that it is into the parietal area. If there is an involvement of your hearing, or there is an impairment of proper memory, sometimes even seizures, then it could be we could suspect the location is in the temporal lobe. And rarely you also have occipital lobe involvement, which is involved with vision. So visual symptoms like diminution of vision, visual auras can be a presentation in your occipital lobe. This is about the cerebrum, or the what you can say, the in layman's language you can say bada dimag. And then there is a cerebellum at the back of your head, which is called as the cerebellum. Cerebellum is if the tumor is in cerebellum, you again have headaches, difficulty or neck pain, difficulty bending your neck, could have imbalance, and occasionally, if not what you can say picked up early, even brainstem can be involved, where you can have involvement of cranial nerves, leading to swallowing difficulties and also speech disturbances. So depending upon the location and the size of the tumor, you can have symptoms. Sometimes the tumors are growing very slowly, and that is the time when these symptoms are gradually accumulating, and it is difficult to appreciate. But then if you compare a patient's history over a period of 1 or 2 months, then definitely you can pick it up. And obviously, if they are benign and slow growing, that is the way you have to detect them. Malignant tumors have to be diagnosed early for a better treatment or better results. And even usually they do not give much chance because they grow rapidly. And there is a very catastrophic presentation with malignant tumors with regards to raised intracranial pressure, or sometimes having fits, or even deficit in terms of your weakness in the arms, limbs, or even involvement of your facial features or swallowing difficulty. So I think these are the common presentations. And now I think to elaborate, we should look at it other way also, that what are the most common tumors in various age groups. So most common tumors in old elderlies are gliomas or glioblast, where you can have a malignant form of glioma called as glioblastoma multiforme. And in the middle age, or you can say age group of around between 20s to 40s, the common tumors are benign. They are usually meningiomas or astrocytomas. And in the in the what you can say, the adolescent groups, you have germ cell tumors and pineal gland tumors. And in young infants and between the age of 0 to 4, you can have cerebellar or the small brain tumors, which are usually medulloblastomas or astrocytomas, which are again benign, but definitely because of the age, they can have poor results. So the proportion of brain tumors amongst all other cancers is less. So, but it is a leading cause of deficit morbidity, and 5-year survival is far less as compared to the other illnesses if you have a malignant brain tumor. So I think it is very important to identify which age group it is, what are the symptoms, and if you are alarmed by the symptoms where you can see the red flags, I think brain imaging should be done early, and a proper consultation would help detecting the tumors.
Well, that is quite a in-depth understanding and explanation of what are really brain tumors, and what are the different types, and how do we sort of get alarmed, and how do we go ahead with the detection. So Dr. Amit Aiwale, actually on that note, really as a surgeon, what is your what's your suggestion, or what can you share about when do we realize that this is a very serious tumor? Is there something like a any other differentiation? Of course, one is malignant and benign, which Dr. Deepak really explained to us. Similarly, are between those also, are there any more serious ones, less serious ones, and what is the real differentiation? If you can explain it in your surgical, from your surgical understanding as well.
So basically, the brain tumor, this word is all actually a very large and very broad term. A tumor means swelling. It is a Spanish word. Tumor means swelling. Any swelling in the brain is called as brain tumor. So it can be, as Dr. Deepak told, it can be a malignant, which is a cancerous, or it can be a non-cancerous. So the non-cancerous swellings, it can be infection also. It can be a simple cyst, watery cyst, CSF cyst, arachnoid cyst, we call it that. Or it can be a tumor, solid tumor. Solid tumor, there are different types of solid tumors. It can be like meningioma, which is the most common brain tumor in the world, in the benign tumors. And it is more common in females. Usually, it is very slow growing. We don't realize, but it usually typically has a headache, which is constant nagging. Whole day, patient has continuous headache, and there is a change in character of the headache once that reaches to a certain size. Many of the times, depending upon the locations, these meningiomas can present early also. Like meningiomas in the CP angle, we call it the cerebellopontine angle, where there is compression on the cerebellum which is associated with the coordination, balance. So these symptoms come early. Sometimes it is in the sella. If it is a cell in the sella, usually it obstructs the it compresses on the your pituitary axis, and it can compress on your optic chiasma. Then I'll just share the slides. Depending upon
Yes,
locations,
we
as Dr. Deepak told, if it is on the right side or the left side of the brain. So the right side of the brain usually presents very delayed, because right side of the brain do not directly have any major symptoms unless picked properly by the consultant. But the left side of the brain tumors usually get presented early because the speech area, affection of the speech area, and the changes in the calculation, understanding, intellectual functions, these presents early. Secondly, the benign tumors most common is the schwannoma. So schwannoma is a nerve sheath tumor, which usually most commonly in the 8th nerve, that is auditory nerve. So these patients presents typically with hearing deficiency, imbalance. They definitely have difficulty in hearing the sharp or the high frequencies, but they can have a low frequency they are able to understand. There is a speech discrepancy. These patients sometimes on phone they can identify few words, but they miss few words. These are very subtle and changes which patients has to realize that these are not just common, and they have to get evaluated for that small symptoms. When the associated nerve most commonly with the schwannoma is 5th nerve. So 5th nerve, there is a tingling pain-like sensation in your jaw, face. This can have difficulty in chewing sometimes. Anytime, even the brushing of the teeth, some patient give atypical pain. This is called as atypical trigeminal neuralgia. So these can present in patients with 5th nerve schwannoma. So depending upon the location, type of tumors, we can have a presentation. Now, another benign tumor is a pituitary macroadenoma. So pituitary macroadenoma is a benign tumor of the pituitary gland. So it can have a secretory or a non-secretory, means it can have a hormonal disturbance or it can have non-hormonal differences. When it presents with the hormonal disturbance, it usually presents early, and it can be a less than small 1 centimeter size, that is called as microadenoma. So in microadenoma, patients have hormonal imbalances, galactorrhea, changes in the menstrual cycle. They may have urinary disturbances, frequency. In other way, there is a non-secretory hormonal pituitary macroadenoma. Patient may have visual symptoms. Most of the time, the compression of the optic chiasma may cause visual disturbance. These patients also have difficulty, but they miss the symptoms because their vision in the lateral part of the eyes is disturbed first rather than the center. So when these patients picked up in your daily life, such as when you want to pick up a glass while eating food, you don't see the glass on your right side, but you see the food in the center. Another example, like a person who is driving car, they can see the properly in the front, but when they try to see in the mirror, their vision is obscured. So these are lateral visions. These are affected in pituitary macroadenoma. So these small symptoms, if they are able to pick up, these patients can get evaluated and get treatment in a proper way. Another pituitary macroadenoma patients even have a single vision loss also. So these are a few common and mostly the presentations of the benign tumor, as I told you. In case of malignant tumors usually they grow very fast. They have very short course of growth, maybe in few months, and depending upon the location or the signs of raised ICP, immediately they present to the casualty. Sometimes the seizure, that is fits. This is most common presentation of the malignant tumors like gliomas. When they are picked up early, they can be treated and they usually present with some emergency in the casualty.
Sure. So I think knowing it from both of you is good. To two similar and different perspectives. So, I think it's going to help the audience really understand and know a lot about this. There are a couple of audience questions which I will, of course, put at you in the end. But having said that, we also looked at the risk factors. And is there also a genetic angle to it, or should we? What is what's the input here? Because we normally know that lifestyle diseases have a genetic component to it. Do tumors also have a genetic component, and is it then the benign ones have more and the malignant ones have less, or how is it like?
So basically, there is a genetic mutation behind the tumor, this thing, because every cell or every cell type has a genetic constitution, and that genetic constitution is in the form of DNA content. That DNA is having all its information regarding its functioning, metabolism, and also what you can say, process of replacing cells, dead cells, all that. Now, when you have most of the genetic component is de novo, or it is not hereditary. Hereditary causes of genetic mutation are less. It is mostly high ionizing radiations and high scenarios, mostly like that atom bomb scenario of Nagasaki, Hiroshima, where you would get that it's an endemic area for malignancies, and obviously radiations to the level of radiotherapy given for other cancers. So sometimes you can have a second type of malignancy with a history of ionizing radiation for prior. So that was the case. And the genetic component, where you have hereditary, there you can have, as I talked about, one of the tumors like neurofibromas or schwannomas. Sometimes you have peripheral nerve sheath tumors as well as eighth nerve tumor, where you can have acoustic schwannoma, and that is a genetic, what you can say, inheritance, where you call it as neurofibromatosis type 1 and type 2. Then there is something called as von Hippel-Lindau syndrome, which is associated with chromosome 3p, short arm of chromosome 3 mutation. So that is again associated with renal cell carcinoma and brain hemangioblastomas, or predominantly cerebellar hemangioblastomas. I think Dr. Amit has one case where the patient had presented with multiple hemangioblastomas. And then there is history of childhood.
That case.
Tuberous sclerosis. That is another.
Yeah. This was a 21-year female who actually presented with severe headache, and she had obstructive hydrocephalus because of the two tumors which were there in the cerebellum, and they were compressing on the brainstem, and there was a hydrocephalus above. So in this patient, initially she landed up in emergency because she had severe headache and altered sensorium. So when she was in altered sensorium, we evaluated, we found that there is a hydrocephalus. Initially, we thought of doing some emergency CSF diversion, but with the medications, she actually settled, and there was a significant clinical improvement in this patient. So we directly went ahead with the proper surgery. We did craniotomy, suboccipital craniotomy, and we removed the two tumors in the cerebellum. And then in the same setting, we put a small chamber that is called as Umaya chamber in the ventricles to drain the CSF if there is excess CSF. But she did not require any shunt. In post-operatively, we evaluated her further, and she had one suprarenal mass, one pancreatic mass. And then when we evaluated, we found the genetic analysis was taken, and she was a candidate of von Hippel-Lindau syndrome. Then she underwent the surgery for the suprarenal tumor, which was a which also got removed, and she improved. She is in follow-up now of almost 6 months, and she's having her life adequate and good life right now.
But having shown this case, I think our message would be that this is very rare. So when we are confronted with a situation where some of the family member has been affected with prior cancer in the family, I do not suggest to get panicky and assume that you have to suspect that similar kind of malignancy is going to be there in your case, because you have to take into consideration the what type of malignancy was it, and at what age it occurred, which sex it was, and then the doctor decides whether it could be really uh, a malignancy. So more than just fearing, I think just keeping a check of the symptoms and consulting the doctor would be enough. That would be assuring. Do not have to panic that you have had one incidence in the family. That means that you might have others getting affected, because it is very rare. So genetic inheritance is rare, but the genetic components comes from the de novo mutations spontaneously occurring in each one's own body, right?
With all of those details that you shared with us, another two main things are: A, do not panic and still be very careful about your symptoms. And if you do get, if you are in any sort of a situation as well, we do have the right doctors here, so you can actually go and consult them at the right time and take the right advice. So do not panic is really a good message, Dr. Deepak, because that's what really happens in most cases. Apart from that, though, I think are there, in your practice, do you see a lot of increase in the number of tumors or increase in the number of malignant tumors as well?
Then again, I think we need to focus on the metastatic brain tumors.
Yes.
Primary brain tumors are comparatively rare. Metastatic brain tumors are the most common malignant tumors, and these are usually related to a lung carcinoma or a breast carcinoma or thyroid carcinoma, sometimes renal carcinoma and colorectal carcinomas. Even there is a differentiation between the skin melanoma and thyroid. They metastasize very highly metastasizing tumors, and they have hemorrhagic component. So it can be a guide for those who have been diagnosed with any systemic or these kind of tumors. Yes, they have to be what you can say continuous monitoring in form of PET scan screening to understand whether there is a metastasis. That would prevent or maybe timely intervention in a metastatic disease would help.
So I think you rightly brought the topic up of continuous monitoring is one thing. So what are the different diagnostic methods that exist? Because like you said, do not panic. The panic starts at that level itself. That when it comes to diagnosis. So when is the right time? One sort of needs this diagnosis, and what are the diagnostic tests or techniques? What are really there, and what are the right ones, and which are the right ones at the right time? So much of confusion about all that.
Initially, when patient usually goes to the doctor, he has either a headache or some neurological problem related to vision, balance, memory, or swallowing, or a weakness. Obviously, we as doctors first check the neurodeficit, and usually for brain tumors, when you are suspecting brain tumors, when it is a catastrophic or event, you start with a CT, but a detailed MRI brain with contrast is a study where you can appreciate this tumor, where you can see the contrast enhancement, the character of the enhancement, whether it is homogeneous. Homogeneous meaning that it is very the contrast is picked up very well, or it is non-enhancing, whether that contrast thing is not getting picked up, and whether there is a characteristic image findings, which we can straight away say that this is a meningioma, various signs in our radiologic features. After having done that, obviously, when we are ambiguous, we go for MRI spectroscopy. So spectroscopy, where you can have various micromolecules, where they are used, micromolecules in form of amino acids, and sometimes in MR spectroscopy, we look for choline peaks, myoinositol peaks, and that helps us to differentiate these, as Dr. Amit was talking about, that these tumors, whether it is an inflammation, whether it's an infection, whether it's a cyst or fluid-filled cyst, or whether it could be just solid benign tumor, or if it's a malignant nature. And then I think there are PET scans to check whether this tumor is just limited to nervous system or the brain, or do you have any primary anywhere else in the body. And when we have diagnosed that this seems to be a malignant one, we need to see whether this location of the tumor is a strategic location, where the strategic location is affecting most important functions, supposedly speech, language, vision. So supposedly these tumors are affecting these symptoms. And now we have to treat these tumors. We have to take care that these functions are not further worsened with the treatment. There is conservation of these functions, and then we go ahead. For that, we do various MR modalities like MR tractography. I think Dr. Amit can elaborate on how to proceed once you know that there is a tumor which is either benign or malignant, and how do you take it from there?
Yeah, as Dr. Deepak told, MRI is still now considered the best and first line of treatment, diagnostic investigation for brain tumors.
Yes.
But during the MRI, there are now so much advances in the MRI that we can actually diagnose the tumor pre-operatively, depending upon the location, size, the structure, the character of the tumors. There are different sequences now available to give us the clarity about the structures involved, to give the clarity about the consistency of the tumor, whether these tumors are hard, solid, cystic, whether these are attached or involving the pia matter, whether there is a edema over the brain that we see. If there is a edema over the brain, that means the pial breach is there, and whether we during the surgery, how complicated it is going to be, and whether there is chances of any brain damage or it is easily separable from the surrounding brain. This we come to know. Now Dr. Deepak just told this tractography. This tractography is recent advances which has improved the surgical outcomes, because these are the tracts which actually control our hand and leg areas, from where our fibers from brain to the spine and then to the legs and hand goes. So these fibers, if we know that these fibers are on the medial side, now you can see here the fibers are on the medial side and on the back side of the tumor. Definitely, if we operate this, considering that this tumor is, we operate from the back side, there is going to be damage to these fibers, and then patient may land up in paralysis post-operatively. So this kind of detailing is now available, where we can plan actually surgery from anterior or directly landing onto the tumor, rather than going into the hand and leg areas where patients can have deficit post-operatively. Secondly, as Dr. Deepak told, PET scan. PET scan is now considered, if at all there is suspicion of metastasis or any infection that we have to rule out. So PET scan can help to identify any other associated primary malignancies. Till now, if there is a single lesion associated with the primary in another part of the brain, still it is supposed to be a curable disease, and we can plan for the definitive treatment after the excision of these single lesions.
Great. So I think also, Dr. Amit, there are so many advanced treatments that exist today, and also Dr. Deepak, a lot. You've been managing holistically. If you would like to add anything to that effect also, so we generally get an overview as to what kind of treatments we can look at least to know it in brief. We will of course cover this in a separate program in more detail as well.
Yeah, this is just, I think up till this is, I think you identify the tumor location and then you decide the approach. So most of the brain tumors are radiosensitive. So usually radiotherapy is going to be a part of their treatment. But then when you get a tumor after excision, you can definitely go for an histopathological confirmation and then go for immunohistochemistry and molecular studies. So this immunohistochemistry can help you in determining your way forward, choosing your therapy, and customizing that therapy. And sometimes the molecular studies are even further giving the precision to the treatment that you can be very sure of your what you can results or the prognosis.
So many times there is a treatment we call as observation. So it is not treatment, but many times these are benign tumors and very small tumors which are not causing the symptoms which patients complain of. If they are not directly related to the symptoms of the patient, and we from the MRI or the scan, we know that this is a benign tumor and the size is very not very significant. We actually follow the patient serially and we see repeated scans at 3 months or 6 months interval, and then take a call depending upon the characteristics of its growth in the serial sequences, how the tumor is behaving, whether it is increasing in size, whether there is a change in consistency. So many of the tumors, this is possible that not every tumor needs a surgery, or not every tumor needs to go for the surgery. Even I being a surgeon, I'm telling this because many of the tumors that do not harm you, they can be just present there, or it can be an incidental finding. But because the now technology is so advanced and each and everyone who has headache goes for the scan and finds that there is some lesion in the brain, so it is not that, it does not mean that you have to go for the surgery. But definitely if the tumor is associated with your tumor symptoms, and if there is a suspicion of change in the character or the malignancy, definitely these has to go for the surgical excision. As I told you, the MRI, these are the shadows. I always say that these are the shadows, these are not the facts. If there is any doubt about the tumor diagnosis, or which is the class of this tumor or the nature of the tumor, definitely we have to go for the surgery. But in brain, we do not have a small biopsy like we take in the other parts of the body, like breast. We just take a needle. But now with the technology that we have at the Solaris hospital, now we have a computer guided, that is a neuro navigation system. So where we can actually just put a small burr hole around 1 centimeter under the local anesthesia. The patient does not have to go for the general anesthesia. And under local anesthesia, we are able to do small needle into the brain and take a biopsy and avoid any major surgery to the patient. So that once we know what is the diagnosis, then actually we can plan the further actual treatment for the patient. So, so the recent advances and the technology that is available now, we can have patients and tailor-made the treatment options for the patient.
Awesome. That's absolutely applaud to both you, Dr. Amit and Dr. Deepak, that we have this kind of a technology which really enables to determine how severe and malignant the tumors can be. And so that with that the question really comes, because this is where people are scared, and I really appreciate as a surgeon you're telling us that every time you don't need a surgery. But so what is the exact time frame, if both of you could tell us, that one should actually go and visit a neurologist or a neurosurgeon? That's the golden question every time.
I think if you want to avoid untoward treatment, and also I think there is something called as disability adjusted life years. So even a headache which is undue or a sudden change in the character or what you can say, it's a new onset headache, such kind of patients should also consult, and that is not in with a fear of having tumor, but I think incidentally you can find something. And as we have been talking about the statistics, so of our brain tumors, not more than 50% or 70% of the primary brain tumors are benign. And amongst them also, the one which is most common, meningioma, is very slow growing, where you can keep on observing it. And if you are doing an annual screen for 5 years, and you observe not significant growth, we can leave it alone. So meningioma is something where you do not have correlation with the symptoms, you can observe. Okay. And then astrocytoma, which is a slightly what you can say, it can increase in size, and also it can cause symptoms. So obviously, as soon as the symptoms come, you treat. If you do not have contributory symptoms, we do not treat in benign tumors. And in what you can say, the malignant, most of the tumors which are malignant are predominantly there is an age population. So you can categorize that obviously above 60s, you will have more incidence of your GBM. It's not that it is rare in 40s or 50s, but the incidence goes on increase. So anywhere, as we talk of the conventional cardiovascular risk factors, above 40 with headaches, I think you can be more cautious, consult early. If you find a tumor, understand whether it is a benign tumor or it seems to be a cancerous tumor from the neurologist or the neurosurgeon, and understand the proper appropriate treatment and go ahead with it. And in young kids and children, where you can have critical locations like posterior fossa, where you can have raised intracranial pressure and respiratory and swallowing difficulties, and obviously they have to be also looked into it. So here again, alarming symptoms would be headaches and vomitings, and obviously some deficit related to that location. So I think this highly vulnerable age group is the kids and the elderlies. Middle-aged people, obviously, again, if you have a symptom in each age group, you have to see it.
So my answer to this is, when of course you get these symptoms, you should go to the doctor. But when you actually have a duo there, one Dr. Deepak Aiwale being the neurologist and Dr. Amit Aiwale being the surgeon. So when we have the complete synergistic evaluation of a problem, I think that's the right thing to do. To come to you when we have those symptoms, and of course we are going to get the complete evaluation of our situation. So from both angles, we will of course come to know. Did Dr. Amit, did you want to add anything to this question? Otherwise, I can go ahead.
Treatment, while when we're talking about the treatment, post-surgery, there are different options available like radiotherapy, chemotherapy, like other cancer tumors. Cancers in the body, in the brain also we have chemotherapy, which is given adjuvant with the radiotherapy. Usually radiotherapy cycles are given a daily with a gap of 2 days between the Sunday and Saturday, 5 days a week, and these cycles are continued. Many of the patients, they are followed up at 3 months to see the scan, how responsive they are to the chemotherapy. Now newer technology like gamma knife, which is available now, which can actually be given to the benign tumors like schwannomas or pituitary adenomas, where the size of the tumor has to be less than 3 centimeters is the last cutoff given. Also associated with the critical structures like optic nerve should be away, and depending upon the location and size of this tumor, the gamma knife can be offered, where patient is high risk for surgery and or do not want to go for the invasive procedure and they want some alternate methods. So this gamma knife therapy is also now available.
Great. So also the other thing is, normally what happens when surgery is suggested, there is, again, like Dr. Deepak earlier said, there is panic or there is scare. And then, do you observe that patients sort of keep running away from the surgeries, or they keep now starting to get opinions at different places? How
Here I
important
would
it is
like
to get
to
a
say something.
surgery done instead of going around and wasting time.
So every dark room is scary. Every dark room is scary. When you put a light in it, you start feeling better. So as a doctor, it's our responsibility to make the patient aware about what is the diagnosis, what is the problem, what is the cause of his symptoms, and take the things forward. So when we educate the patients about their conditions, about the treatment options, and about the procedures they have to go, usually they understand the criticality, and when the patient and doctors, though both are in hand to hand going for the treatment, the patient actually get the proper results. So I would say yes, patients are definitely scared of the word brain tumor, but when we are there to discuss the things and we try to educate them about the problem, I think they build up the confidence to go for the treatment and then have a proper results.
We have a couple of audience questions which have come, actually more than that. One of them is, coming from, of course, a woman saying that there's migraine can sometimes be accompanied with aura, and normally during puberty or menstrual cycles this can be. So does one need to really fear and go for a checkup for tumors, or is it could it just be a normal migraine?
So basically, when for a headache to get into a definition of migraine, you should have at least a consistent pattern for 3 or more months. And if it is a more than 3 months of headache and just headache, no new additional change in the character or worsening of intensity of headache or location of headache or any associated symptoms like vomiting or visual symptoms or any deficit in the limbs. I think if you have been diagnosed with migraine, the migraine patients do not have to think of a possibility of brain tumor until and unless you have any additional symptom or worsening, which is beyond what you can sometimes you call it as a thunderclap headache. So if it is a worse headache, which she has never had similar kind of headache in the past, definitely it is alarming. You have to consult the doctor and do in brain imaging. But beyond that, there should not be any anticipation that a migraine correlating with tumor. No, I think that is no correlation with migraine and brain tumor.
Yes.
Yeah.
Again, no need to panic and not overthink. Yeah.
Just a small comment. When the female patients, they say that there is menstrual disturbance, definitely it is most of the gynecological problem, and they should definitely
There
consult
is something, there's something called as catamenial headache. So that is during the menses, women get a headache, and that is a patterned headache. So if it is there, then it could be a catamenial migraine or a catamenial headache. But again, there has to be some additional feature, and then there is a possibility of thinking in those terms. But with your continuous patterned headache, I think you should be assured.
No, I was just discussing regarding the menstrual disturbance and associated with any other symptoms. Many of the times, pituitary macroadenoma, they can actually present with to the gynecologist, and they get treatment for the PCOD or PCOS, and they are many times misdiagnosed and continue to take the hormonal therapy, but not properly go for the brain imaging. So these patients actually have to be asked in detailed history rather than going for imaging. You have to get the proper history. In young adults, married, there is a decreased sexual urge. There is females, they have galactorrhea, like milk secretion from the breast. These small symptoms, the gynecologists have to go in detail and ask the patient. And when these symptoms are available, associated with the visual disturbance, I think these kind of patients needs a brain imaging, and then they can be we usually find that such patients have pituitary macroadenomas.
It's also alarming, but good to know actually that.
I think the message is same. Key wherever you have an additional symptom or a worsening of original symptom beyond which you have never experienced earlier, that until that time you do not have to get alarmed, but you have to be aware about your or more vocal about your symptoms. Sometimes patients do not communicate or the doctors and patient communication is such that you do not convey the information. So I think in conveying information in full, if it is not related to headache, still you should report your symptoms related to other symptoms to the doctor.
And then the last couple of questions, one of course for Dr. Amit, essentially because this is coming from a person who probably has the history or knows someone in the family, that can patients with tumor heal completely? Can patients with tumor, if they've gone through surgery, can they heal completely? And can they just go back to a normal life again?
Yes. I would say only 1/5 of the tumors are malignant or high-grade tumors. Less than that, all are benign and treatable. Like I told you, meningioma, schwannoma, pituitary adenoma, these are benign tumors. Lymphoma, this is considered another tumor which is in the response to the chemotherapy, and we are completely curable. Now the technology and treatment options are such a possible that patient can go back to their normal life without any deficit and without any other problems. So last week, I just like to share one patient who presented to me with a colloid cyst, which was actually obstructing the third ventricle, and he had hydrocephalus causing the raised ICP, and he was brought in casualty unconscious completely. We settled the patient and we did an endoscopic excision of the third ventricular colloid cyst. And 1 month back, patient came to me with a token of appreciation and saying, "Thank you, I'm back to my job now." So there are, this is very routine and this is very common now that patients can go back to their working condition. It is not about saving the life now. It is about the quality of life and working quality of life rather than just the quality of life. Whether you are able to do the productive life again. So that is now possible.
Great. And lastly, the question is that, are there any suggestions how to prevent tumors?
So definitely prevention, there is till now no direct correlation of any malignant food items or any exposure, but definitely for all cancers, it is said that smoking, alcohol, radiation, prolonged use of contraceptives, actually contraceptives can increase the meningioma, size of the growth of the meningioma. This has been documented by some studies that use of more contraceptives has correlation on the growth of meningiomas rather than the development of meningiomas. So definitely we cannot say that specific cause for the tumors, but there are preventable things which can be avoided.
Okay, my last question to Dr. Deepak and both of you, of course, is, how does one decide on which center to actually go to when it comes to any sort of neurological treatment? And this question is apt really to both of you because both of you are really the two strong arms of neurology, and you have the Institute of Neurosciences at Solaris Hospital. So, what sort of a center should people approach when they are suffering from any symptoms, basic, but also when they have to go for a surgery?
I think initially, if a person is faced with such diagnosis that there is a tumor in the brain, and the doctor is able to give them a framework where they know the roadmap, the end result, what to expect with a probability in mind. And obviously, he understands that he or the other doctors in his team can be there with them throughout this journey. So this roadmap where you can get a what you can say companion who can hold your hand and take you through this journey. I think any center of that sort. This is one way of looking at it, but obviously a doctor who can give you a prompt answer to what could be the probability and what could be the roadmap. I think that adds, as Dr. Amit gave an example, the one who can switch on the lights in your dark room and
Yes.
who can assure you. So I think with proper expertise in that field, proper infrastructure or the facilities where you have such, and a proper informed consent, what you can say, that they have to be, they have to understand what they are actually facing, and obviously they not be terrified. And they are going to be accompanied by their doctor in this journey.
Certainly, I think. Dr. Amit, did you want to add anything? I mean, when it comes to surgeries,
So, brain tumor is something like these patients definitely come to me with 2 or 3 opinions already, because now the world is so small. You always have a second opinion available. But as I told you, when you have a good understanding of and the experienced person telling you about the conditions and giving you the comfort and giving the confidence of going into the major surgery with the technology in the hand, we tend to commit to the patient. So that is what every patient has to go ahead and research himself. Get the when you go for a doctor, you make your list of questions to the doctor. It is not just go and visit the doctor, but it's our responsibility as a patient to prepare a list of questions which you want to ask to the doctor. And when you get complete satisfaction of your all the answers, you are definitely going to take a proper decision with regards to what is the treatment plan, what is the diagnosis, how many stay, how much will be the stay in the hospital, what are the complications expected, what are the risk factors associated. All these questions should be asked to your doctors, and I already encourage my patients to get this knowledge. And if at all they have any doubt, we already offer a second opinion from our side, and then get the complete cure and understanding of the treatment.
Great. So should I sort of summarize this way, that if someone has symptoms, they obviously come and see Dr. Deepak first and get their situation analyzed unless it's as serious, and then we have a synergistic opinion with Dr. Amit there, and of course Solaris also has all the diagnostics under that one roof. So get done with that, and then if a surgery is needed, you have a high-end technology available as well out there. So probably choosing a center like that is what is the best for a patient, right? Having said that, that's really my closing note, and I've really gained so much of understanding from you all, having been in this field as well, yet so much to learn from both of you. But I would not leave you without leaving the audience with some takeaways that they should remember and for their good.
So,
I think, yeah, Dr. Amit.
Yeah. So I would like to say that world is evolving so fast. The technology is evolving so fast. Not just the medical science, but the mechanical science, I would say, and the technology with regards to the instruments, equipments, those available for us as a surgeon. It's making our job so easy. Now we have facilities like awake anatomy, where we can actually do patients have continuous talking to you, speaking to you, moving your hands and legs, and we can do the tumor surgeries. So we know that how much tumor we are able to remove, and without a deficit, patient is not under anesthesia. So when he gets back to the ICU or the post-operative care room, he definitely knows he's in the same situation how he came into the operation theater. We have now minimal access surgeries like endoscopy. We can do just a small burr hole, and we can remove the tumors from third ventricular, pituitary macroadenoma, where we can do the tumor removal from the nose without any scar. That is called a scarless brain surgery now. That is possible. So the technology has evolved so much. I would say the word now, the scare that has will be less in patient's mind, and we should be open to present our symptoms to doctors early and get the proper treatment.
With that note, I think we will end today's program with the promise that both of you will join us for more sessions. And we're not going to leave you because you really complete the whole discussion, both of you put together. We will of course want to know more about more different conditions that are, and brain is such an critical topic for all of us. So with a promise from you, I think we will close this session. Thank you very much, both of you, for taking out time on a Sunday and giving so much of knowledge in depth that I'm sure we are all going to take away a lot of things from this. And when we are in need or understanding we understood what symptoms we have to look out for, we have to reach out to you. So thank you so much, and looking forward to more.
Thank you.
Thank you.
Thank you, Rajashree. Yeah.
Thank you, audience, for joining us,
It's been a
and
pleasure.
we
Yes.
will be back soon.
See.